Hi, I'm Danny Gasparini, and welcome to this segment of Penn Voice. I'm joined today by Dr. Jack Higgins, who is the President and Chief Medical Officer for Global Telehealth Network. Dr. Higgins, welcome.
Thanks for having me.
Global Telehealth Network is a nonprofit, but I think people might not know exactly what it is that you were inspired to do with this company. So give us a little rundown of what you do.
Sure. The Global Telehealth Network is a group of physicians internationally who are willing to volunteer their services to see patients in places where there aren't any doctors, or at least not enough doctors. So we're starting out doing that in Africa, in Uganda and Tanzania, and then soon here in the United States as well in underserved areas.
And how are you going to do it?
Well, basically, if you have a nurse who's out in the field somewhere, say in Uganda, who has a problem with a patient that she can't quite solve by herself, she'll be able to log on to the website and be matched with a volunteer physician somewhere in the world who can help her out. If it's a physician somewhere, like starting in Tanzania, who has a problem, a primary care physician like me, they can log on to the website and get the specialists they need in whatever specialty.
So do you envision, now this is something that you're just starting to launch, so you've got your physicians around the world secured in volunteering in various specialty areas. You've already sort of identified where the greatest global need for health or the biggest gaps are for health access. They will, whoever the end user is, whether it's an individual, a nurse practitioner, or a physician, they'll need access to the internet and be able to, now will they have a live conversation with the physician on the other end, or will it be something that is then sent via email or taped message and then a taped message back?
It'll be a live, interactive, real-time video conference. So you have both video and audio. And with the combination of the two, you can diagnose and treat a lot of things that you couldn't with just a phone call.
Right. So along with the telehealth services, will you plan on trying to provide some of the other, whether it's medical technology or whether it's access to prescriptive drugs or any of the other kinds of health aids, or is this going to be basically a professional services conversation?
In every case, we'll be partnering with NGOs, what they call nonprofits, any place except the United States. And those NGOs have staffs, they have access to medications and so forth. So in every case, we'll be working with somebody who's there on the ground that has a system already in place and usually integrated with the Ministry of Health in that country as well, so that they can take care of all that. All we're really doing is providing the physician expertise that they can't get locally.
Right. And you mentioned Uganda, Tanzania are some of the examples. What about the United States? We hear every day about health access issues or health information issues here in the United States. Will you be able to affect that conversation?
We will. There are a lot of underserved areas even here in the U.S., in rural areas and urban areas. And in fact, I'm on the board for a group called Rotacare Bay Area that runs 10 free clinics here in the Bay Area, all the way from San Rafael down to Monterey, with 3 in the East Bay, where we have volunteer physicians and nurses, and most are primary care, and it's difficult to get specialty consultations for free. So that's why our network will come in to help them out too.
And I think when we look at our community hospitals, not only in the United States but throughout the world, there's only so much specialty care that one can get. We can't all be specialists in a particular cancer. So the access to someone who is a specialist in a very particular disease state, I think is going to be tremendous in having at least a peer-to-peer conversation between a physician and physician, or nurse practitioner and physician, when you're seeing some of these very specialty cases, as well as when you're seeing the general cases of influenza or a respiratory issue as well.
And that's available to some extent already. There are a number of services around. For example, within the Sutter Health Network, Palo Alto Medical Foundation, for example, where I go for my care, or in Kaiser, they're using telehealth now extensively to the point where it's over half of the visits at Kaiser are virtual visits, whether it's a video or a phone or email or text. They're doing a lot of what they do now online. And what we want to do now is offer those services for people that can't afford it.
Right. Now, let's talk about efficacy. So the patient is not necessarily in the room where the physician is, or the consulting physician is not in the same room that the requesting physician is. How is that dynamic? Do you find that it's going to be a successful dynamic?
It works really well. It's been going on for decades. In fact, I started seeing patients that way 28 years ago. When I was in practice in Chico, I was taking care of folks in a village up in the Trinity Alps in Northern California, where they had no physician, just a nurse practitioner. 4 days a week. On Mondays, they'd call me up on the phone and we'd connect. Actually, we're telephone lines because the internet didn't have bandwidth adequate for video at that point. And it worked very well. And people ask, well, how come you can do it if you're not in the same room? Well, I have 5 senses. I can say I've never tasted a patient in all my 40 years or so in medicine.
And we're not going to anymore.
No, I haven't smelled many where it made a difference in the diagnosis. So that leaves touch, sight, and sound. And the touch can be done by somebody else in most cases. In the case of the Mad River up in Northern California, that was the paramedic that ran the ambulance service. In Africa, it will be the nurse or the doctor or even a community health worker in some cases who is there with that patient.
Right. I think there is something comforting, even if we're seeing your face or the physician's face over a FaceTime or some kind of web access. Just seeing the physician actually speak to you or speak to whoever the end user is, there is something comforting about that. And I agree with you. I never thought of it that way, that just because it might be over a piece of technology doesn't mean that the warmth and the discussion won't be there for the end user.
And in terms of the information we have, we're getting a history already from that nurse or doctor or whoever. They'll be entering data into an electronic health record. So when the doc who's the consultant, first sees the request, they'll be able to look at it and make sure it's something they're going to be able to handle based on that history.
So this is a tremendous service that you're going to be providing to our most vulnerable around the world. Your physicians are volunteers, so we thank them so very much. But how does an organization like yours, even though it is a nonprofit, sustain itself? How will you be either charging fees or receiving revenue to support this endeavor?
Well, initially we're depending on donations from individuals and family offices and so forth, and then later when we have more of a track record, we'll be able to attract larger foundation money. But that's not good enough. It has to be something more sustainable. So what we're actually doing is also starting 2 for-profit companies on the side. They aren't started yet, but we plan to soon, with the idea that they'll work in close cooperation and they'll provide some funding from their profits to the nonprofit. And we have friends who've done something similar and been able to cover all the overhead and the salaries with those revenue streams from the for-profit entities, which are also doing great things in the world at the same time. And by doing it that way, we can then go to the major funders and say, well, hey, 100% of what you give us will go toward program and not toward our overhead and salaries.
Right. And I think today, if people want to jump on your website, we'll make sure that it's posted on the banner. They can look at what you're doing when you plan to sort of launch the services, and also how do they support the organization through donation or support in a different way. So that was prevalent right on your website. When you were determining there was a global need for this, what were you looking at as far as the numbers of individuals? It must be in the millions of those that aren't receiving quality care or even access to a conversation about how to improve their health.
That's true. There are tremendous populations out there, and it's hard to give a number because we're looking at not only medically underserved areas like in under-resourced countries, but disaster areas.
Right.
How do you put a number on that? And refugee camps, our second project in Uganda actually will be just outside a refugee camp that has 100,000 people who've been fleeing from the Congo in the midst of the political strife there. And a company, a nonprofit in the Bay Area, has started a school there, a boarding school for 500 students. And there's one nurse taking care of all of them. We're going to provide her with consultations. So we start adding all those things too, schools and refugee camps and so forth. It could be a lot of people.
Right. Well, thank you, Dr. Higgins, so much for this conversation. I'm hoping that through this program, people finding what you're doing through the internet, that there is a lot of community conversation about how to support the global telehealth network. Thank you for your discovery. Thank you for what you're doing and bringing this forward to a better global community. That's, I think, all I can say. And we'll see you next time. I want you to come back and tell us more about the launch and the folks that you are now serving.
Be happy to. Thank you so much.
Thanks so much, Dr. Higgins, and we'll see all of you next time on Penn Voice.